Leukemia means white blood cell cancer in the blood, leukemia. And what I want to do here is show you how simple the diagnostic pathway is, and that there's only really two presentations, even though we're going to talk about 4 different cancers. And there's only a handful of tests you can get to make the diagnosis. I want to show you that just to imply that, hey, this is probably not going to be the question. We're going to finish up the lecture with all the details, the nitty-gritty details you need to know about each individual cancer, because that's probably where the test is going to go. So let's start off with the 2 presentations you're going to see. And that is going to be the chronic patient and the acute patient. The chronic patient it's called chronic because there are chronic cells. Chronic cells mean mature. They're mature leukocytes. That is, there's very little cytoplasm and the nucleus is mature. If you look at a chronic cancer cell, it is very hard to tell that apart from a normal mature leukocyte, except that there's a lot of them. And because they're mature, they don't wreak a lot of havoc. In fact, there can be a ton of them, and the patient doesn't know. So the way the chronic patient is going to present is an asymptomatic, severely elevated white count. Now you can have cancer with not this severe of an elevation, but what you're going to see on the test is a white count greater than 60, and nothing is going to get your white count greater than 60 except for cancer. When you see this ridiculously high white count, the next step is to check a differential. And what it's going to tell you is there are either going to be neutrophils, that is polys, or lymphocytes. And if you have polys, you have chronic myeloid leukemia. And if you have lymphocytes, you have chronic lymphocytic leukemia. Regardless of which one it is, the next step is clear. You're going to get a bone marrow biopsy. It's going to confirm the diagnosis and allow you to do cytogenetic analysis to figure out the details of this particular cancer. Way above the level of an M3, just know that really high white count differential separates CML from CLL, and a bone marrow biopsy confirms it. We'll get into the details here, but CML is treated with imatinib, the tyrosine kinase inhibitor, and CLL is variable. If the person is young and there's a donor, you want to do a stem cell transplant. If the person is old and symptomatic, they get chemo. But if the person is old and asymptomatic, you do nothing but watch and wait. Chronic cancers present with an asymptomatic elevation in the white count. Acute cancers, on the other hand, if you look at the smear, you're going to see a big, angry, nasty cell. Lots of cytoplasm, small nucleus. This is a blast cell. Blast cells wreak havoc. They churn up the bone marrow because all these cells are being pumped out really fast. They crowd out the marrow so that no good cells can be made, and that includes problems with the other cells from the marrow. So you lose platelets, you lose blood, and you lose good leukocytes, which means you're going to present very symptomatically. You get infections and fevers because you don't have white blood cells. You become anemic because you don't have red blood cells, and you bleed because you don't have platelets. You may also present with bone pain. These patients are very obviously sick, and they're asking you to do some tests. But their white cell count will not be as elevated. It might be in normal ranges or slightly elevated, so you might think they're just septic. When you do the smear, because it will be abnormal, whenever you have an abnormal CBC, you get a smear, you're going to see the blasts. You do the same thing as chronic cancers. You say, is it neutrophilic or is it lymphocytic? If it's neutrophilic, it's AML. If it's lymphocytes, it's ALL. And regardless, you are going to get, next step, a bone marrow biopsy. Now, caveat here, with the bone marrow biopsy, you're looking at more than just cytogenetics. You're looking for greater than 20% blasts. And you can, with these acute cancers, with the blast cells in the blood, also look at the peripheral blood. So the diagnosis can be made with 20% blasts on peripheral blood or the bone marrow biopsy. But you, as the M3, are always going to choose bone marrow biopsy to confirm the diagnosis of these cancers. Some things you should know: AML can be treated if it's the M3 variant with vitamin A. If it's not M3, it's chemo. ALL is treated with chemo, but you also have to prophylax the CNS. Okay, that's the drive-by, just to show you that the diagnostic tree is not complicated. You're going to get a biopsy. So that's not what they're going to ask you. They're going to ask you the nitty-gritty details of each individual cancer. Let's start off with AML first. And the pathology is in the name. It's acute, so they're going to be blasts, myeloid, neutrophils, leukemia, cancer in the blood. The patient is going to have an acute presentation, and the general age is around 67. But the person is going to have some sort of exposure. And that exposure usually is to benzene or to radiation. Or that person has had CML and is undergoing a blast crisis. The diagnosis is going to be made first with a smear showing you the blasts, and then you get a bone marrow biopsy showing you greater than 20% blasts. What they're going to ask you about the bone marrow biopsy is not that there are blasts, but that you confirm the fact that it's myeloid. Myeloid positive myeloperoxidase. The treatment for AML is going to come down to whether or not it's the M3 variant or not. If it's the M3 variant, you treat with all trans-retinoic acid, vitamin A. If it's not M3, you choose chemo. You do not have to know all the different variants of AML. Just that M3 is treated with vitamin A and everything else is treated with chemo. You do not have to know the chemotherapeutic regimens. So what you should look for then is M3. And they will do that to you by showing you a picture of a blast cell and showing you the hour rods. So chances are, if you have a picture of a blast cell and it's a leukemia question, they're probably showing you the hour rods, those little needle-shaped things in the cytoplasm. But you have to be careful because they could be doing that to show you that there are not hour rods. So scour that photo, try to find the hour rods. The next cancer we're going to talk about is ALL. The pathology is in the name. Acute means blasts. Lymphocytic, lymphocytes, leukemia, cancer in the blood. The patients are going to be presenting with an acute picture: bone pain, fever, infection. And this is a disease of kids, age 7. Young adults can get ALL, but you should slot this disease as a pediatrics disease. The diagnosis is going to be made with a smear showing you the blasts, and it's confirmed with a bone marrow biopsy showing greater than 20% blasts. But just like the myeloperoxidase of AML, ALL will have some markers. CALLA and TDT. You have to memorize TDT, but CALLA, ALL is in the actual word. The treatment for ALL is going to be chemotherapy, but you are going to prophylax the CNS with Ara-C, plus minus radiation. So you make the diagnosis on a bone marrow biopsy, you do the lumbar puncture. Even if the lumbar puncture is negative for cells, you are still going to give intrathecal chemotherapy prophylaxis. For whatever reason, ALL gets into and hides in the CNS. If you find cancer in the CNS, you're going to use radiation. Those are the acute cancers. We're going to do the chronic cancers now. CML, chronic, mature cells, myeloid, neutrophils, leukemia, cancer in the blood. The patients are going to be a chronic picture. So generally they will be asymptomatic and have an elevation in the white count. These patients are around middle age, 47. The diagnosis is going to be made by getting a diff showing you a bunch of neutrophils. Then you get a bone marrow biopsy to confirm it. And here you're looking for a couple of things. They all mean the same thing. You're looking for the Philadelphia chromosome. The Philadelphia chromosome is the translocation 922, BCR-ABL. If you see any of these words, 922, Philadelphia chromosome, BCR-ABL, they're telling you it's CML. And the reason why they make such a big stink about this is that CML is our first targeted therapy. All of these things mean the same thing. We have a tyrosine kinase which is causing overactivity and expressing cancer. So if we had a tyrosine kinase inhibitor against this particular translocation, we could essentially stop the cancer. Now it's not true the way that works out, but we built imatinib as that targeted therapy to target that translocation. We have newer tyrosine kinase inhibitors that work when imatinib fails. But eventually the cancer is going to escape the drug and they will undergo a blast crisis in which CML turns into AML. The last cancer is CLL. Pathology is in the name. Chronic, mature cells, lymphocytic, cancer of lymphocytes, leukemia, cancer in the blood. The patients are going to have a chronic presentation, so asymptomatic elevation in the white count, but they're going to be old, 87 years old. The diagnosis is made first with a diff, which shows lymphocytes, then a bone marrow biopsy. And there isn't really anything on the bone marrow biopsy that you have to memorize for CLL. CLL is going to be probably a do no harm question because most of these patients are asymptomatic. And like prostate cancer, they get it old, they die with it, not from it. So if the person is old, that is greater than 65, and they are asymptomatic, you do nothing. Regardless of how high the white count is, unless there are symptoms, you do nothing. If they're old, greater than 65, and they develop symptoms, and they may have symptoms from hyperviscosity syndrome, there's so many white cells, their blood becomes sludge, headache, bleeding, etc. If they develop symptoms, then you start chemo. If the person is young, however, and there is a donor, this is the person you want to give a stem cell transplant to. Okay, let's back up and highlight the things you need to know. Figure out if it's M or L. Everyone gets a biopsy. But in the specifics of each one, there's going to be some details. This is how I remember it. The L's are the extremes of age. ALL is a pediatrics disease. CLL is a geriatric disease. You can get AML by having CML. So CML must come first in age to AML. ALL 7 CLL 87, CML 47, AML 67. For AML, look for myeloperoxidase and the picture of our rods. If you have our rods, use all-trans retinoic acid, vitamin A. ALL is a pediatric disease. Look for CALLA, TDT markers, and prophylax the CNS with RSC regardless of anything else. CML, translocation 922, BCR-ABL Philadelphia chromosome, use imatinib. CLL, do no harm. If they're old and asymptomatic, do nothing. That's leukemia.